Good afternoon or good morning if you're joining from other time zones around the world. I'm Dr. Chelsea Larkman. I'm a postdoctoral researcher at the University of Sydney and affiliated with the Aphasia CRE, and I co-host this series with Dr. Rebecca Sullivan. Before we begin, I'd like to acknowledge the traditional owners of the lands across Australia and pay my respects to elders past and present. I'm joining you today from Gadigal country, and I extend my respects to all Aboriginal and Torres Strait Islander people who might be with us. So we are delighted today to be hearing from Dr. Monica Norvik, who will be presenting her work, Assessment in Multilingual Aphasia, Challenges and Clinical Strategies. A little bit of housekeeping before we begin. If you have any questions, please pop them in the Q&A box rather than the chat box. So feel free to add any thoughts or questions as they come up, and you can upvote any questions that you'd particularly like to see answered at the end. And we'll try and cover as many as we can in the discussion when we finish up. So it is my great pleasure to introduce Dr. Monica Norvik. Dr. Norvik is a professor of speech and language therapy at the Arctic University of Norway and an adjunct professor at the University of Oslo, both in Norway. Dr. Norvik is a qualified speech and language therapist with over 20 years of clinical experience, and she holds a PhD in clinical linguistics from the University of Oslo. Monica's work focuses on multilingual language disorders in adults, especially aphasia and dementia, and her research aims to develop equitable, linguistically informed assessment and intervention practices for multilingual and Indigenous language speakers. Dr. Norvik is the principal investigator of Sami CAT, which is a major research project developing aphasia assessment tools for North Sami, an Indigenous language of Northern Scandinavia. Monica also leads the Multilingual Aphasia Project within the Collaboration of Aphasia Trialists, and so is contributing to international efforts to improve assessment and treatment of people with aphasia across diverse linguistic backgrounds. She's also played a key role in adapting important clinical instruments into Norwegian, including the bilingual aphasia test, the PALPA, and the comprehensive aphasia test. So, Monica, I'll hand over to you.
Thank you so much for the nice introduction, Chelsea, and I will try to share my slides here. I hope this works.
Looks good.
Perfect. Thank you so much. Thank you for having me. I would have loved to be with you in Australia, in Melbourne, but I'm here in sunny Norway, so it's fine. So thank you so much for the invitation, and thank you, Chelsea, for the nice introduction. So I've been asked to present on the challenges of assessing multilingual individuals with aphasia, and also try to share some concrete tips for the clinicians in the audience. And in fact, I am being contacted by many SLTs who are uncertain about what to do and were struggling with navigating in the growing body of research. So we'll look into what we know and what we as clinicians need to consider when assessing multilingual individuals, and how to try to provide more equal services. And I hope this talk also can be relevant to educators and researchers in the audience. So we know that more than half of the world's population is multilingual, and the amount of multilingual individuals is growing. And one cause is the increase in migration, which leads to growing hyper-diverse environments, where we have individuals with multiple linguistic profiles. So we have monolingual speakers of minority languages, we have multilingual speakers, which we will concentrate on today, and we also have users of dialectal varieties of local languages. And these multilingual individuals, of course, live multiple life realities. So they have different socioeconomic circumstances, different educational experiences, sociocultural histories, and also different worldviews. So due to this increased mobility, we as SLTs should be prepared to serve more culturally and linguistically diverse populations. So how prepared do we actually feel? This question has been asked in a couple of surveys. So when asked to what degree their education prepared them to work with multilingual clients, this American study showed that 80% of the SLTs say that they feel prepared to no or to minimal degree. And only 4% say that they really feel prepared. When we replicated this study in Norway, we found the same pattern exactly. Only that the great to very great degree has decreased to only 2% for the Norwegian SLTs. Within the clinical and research network, Collaboration of Aphasia Trialists, we have a working group working on multilingual aphasia practices, the Multilingual Aphasia Project, the MAP group. So more recently, we conducted a global online survey on multilingual aphasia practices. And we asked SLTs from all over the world about their assessment and treatment practices. We got more than 400 responses from 60 countries across all continents, and they responded to the same question, among others. So how prepared do you feel? How did your education prepare you? And maybe some of you in the audience may have been among those who answered the same question. Thank you so much if that's the case. So I'm happy to that the numbers in this global survey are more positive than in the American and the Norwegian surveys, even if half of the group still feels minimally prepared. Of course, these SLTs are a far more diverse group than in the two other surveys. So we cannot know whether the education in fact has improved in the past couple of years, or if asking SLTs with more varied linguistic and cultural backgrounds may better explain these findings. So when I talk about multilingual individuals today, I'm talking about users of two or more languages. And this includes both balanced multilingual individuals and also those with one dominant language and other languages in which they are more or less proficient. And their multilingualism, everybody's multilingualism, changes throughout the lifespan and also across different contexts. And of course, these multilingual individuals are not only the sum of the languages. So our clients often bear with them a mix of different cultures, which may and probably are impacting our communication and also the attitudes. So there is some uncertainty among SLTs, and I will point to some of the challenges. One big issue is that for multilingual individuals with aphasia, there are no established guidelines or recommendation for optimal management. So I don't blame the SLTs for being a bit insecure. Because how to best capture pre-stroke proficiency and post-stroke language abilities? How do we best assess all relevant languages when there are some limitations in the assessment tools that we have? And I will point to the limitations in this talk. Who should conduct the assessment? A clinician, an interpreter? We will go into that as well. And how do we score and how do we interpret the scores across the different languages? So all of these can make us a bit uncertain. And also, in addition to that, we know very little about languages other than English, even if we know that aphasia manifests differentially depending on the linguistic and cultural contexts. So my aim for today's talk is to try to raise awareness about the linguistic and cultural biases in our tools and our practices, and also to discuss what may be relevant options for assessment. Okay, so how do these challenges translate into real-life clinical practice? We'll start by examining the difference between monolingual and multilingual aphasia, beginning with an example of a monolingual individual. So this Australian lady, when she acquires a stroke, we can assume that her English was good before the injury and that her language difficulties are caused by aphasia. We will assess her with tools that are normed and standardized in her language for her culture. And when we plan our treatment, we will use the assessment results and plan our treatment according to her strengths and challenges and goals, and the aim will be to enhance her communication in English. For multilingual individuals, it's not that straightforward. For this Mandarin English woman who also acquired a stroke, we can assume that she had high proficiency in Mandarin before the stroke, right? But what about her English? We don't know anything about her English. This lady tends to struggle in English and has some language mixing to Mandarin. But are her language difficulties caused by the aphasia, or were their languages different to begin with? So how can we figure out what is what, and how do we distinguish between premorbid proficiency and post-stroke language abilities? And why is it important to do that at all? So we will look into that shortly. But first, I also want to introduce you to Rami. Rami is a man from Turkey who used to live in Denmark. He lived in Denmark for 20 years before he returned to Turkey 10 years ago. And ideally, I would want to play a video clip of Rami for you, but I don't have the rights to do that. So you'll need to Google him after the talk if you're interested. It is very interesting. Okay, so when Rami suffered a stroke, he hadn't spoken Danish since he left Denmark. So for about a decade. And after his stroke, he speaks mostly Danish, and Turkish is almost unavailable to him. He has some language mixing to Turkish, but he basically speaks Danish. And this causes problems in his family because not all his family members speak Danish. His wife doesn't speak Danish. And his daughter says that he's very upset because he thinks he has lost his own language. It is reported that his doctors expect him to regain his ability to speak Turkish as his recovery progresses. So how do we explain how this can happen? How does someone wake up after a stroke and suddenly speak a language they haven't used in more than a decade? This question was asked to a Danish brain researcher. He was asked to try to explain Rami's case. And he said, there is a specific area where we learn language, which is the center of that activity. There are neurons that are specialized for understanding the language one grows up with. So Turkish in Rami's case. And he says that if one learns a foreign language, as Rami did, it will be stored in a different area of the brain. So can this explain what happened to Rami, and does it reflect what we know about language organization in the brain? So the Danish researcher is correct in that there has been some debate in the literature regarding the representation and processing of multiple languages in the brain. And some decades ago, researchers even believed that the different languages were processed in different hemispheres, so L1 in left hemisphere and L2 in the right. This has been debunked, but we can think of it in two different ways. So one perspective suggests that the neural networks addressing different languages are distinct and non-overlapping, and that the network responsible for processing a specific language may be related to the age of acquisition or the proficiency of that language. So this is maybe what the Danish brain researcher alluded to when he tried to explain Rami's case. The other perspective maintains that multiple languages are served by overlapping neural networks with control mechanisms that allow for appropriate language activation and also inhibition during language selection. Today, most researchers agree that a common neural network supports all languages learned and that we cannot switch off one of the languages, so there is no language switch. So all languages are thought to be active at all times. And this is important for us when talking about assessment, because if you want to assess one of the languages, the non-target language needs to be inhibited. We know that multilingual individuals who acquire aphasia can experience different so-called patterns of impairment and patterns of recovery. And in parallel impairment, the different languages will be impaired to the same degree relative to the proficiency before the stroke. So if two languages were of equal proficiency before the stroke, both will be impaired, but to the same degree. In non-parallel impairment, on the other hand, the languages are impaired differentially, again, compared to their pre-stroke proficiency. So two languages with a similar proficiency when acquiring a stroke, this can lead to that one language is more impaired than the other. In such cases, when one of the languages appears less impaired than another, we know that factors such as earlier age of acquisition or more extensive use at the time of the onset, and also pre-stroke proficiency may predict the differential degree of impairment. Okay, so the different languages can be impaired to different degrees. And to complicate the matter even more, the different language modalities within the different languages may also be differentially impaired. So it can be more difficult to write than to read, for instance. This we also see, of course, in monolingual aphasia. So it appears that linguistic resources and impairments may be visible in only one of the languages. So what should we expect as clinicians when we get a multilingual client into our offices? What to expect? Better L1 or better L2, L3, and so forth? Previous reviews of the literature have shown mixed findings in the patterns, some stating that parallel impairment is more common, and others that non-parallel impairment is what we should expect. So some years ago, we explored this in a meta-analysis, including 65 studies and 119 individuals, multilingual individuals with aphasia. And we investigated whether the people in this study were likely to exhibit better performance in L1 or L2 following a stroke. And we also wanted to investigate whether these factors, factors that we know affect language processing, affect the consequences of aphasia in L1 and L2. Now we'll jump to the findings. So overall, for the multilingual individuals as a group, we found that L1 was significantly better preserved than L2. But the finding was indeed modified by some of the different factors. We found that age of acquisition played a role. So the early bilinguals, those who had acquired both languages before the age of 7, they showed comparable performance in both languages, so parallel impairment. And also premorbid proficiency seemed to play a role. There were only 4 individuals in our sample with higher L2 proficiency. But those 4 had performed better in L2 following the stroke. But the individuals who had higher L1 proficiency or equal proficiency of the 2 languages, they showed the same pattern that we observed for the group as a whole, so better L1 than L2. And we also examined whether language use played a role. And we found that those who had used their second language more had parallel impairment. And finally, linguistic similarity between the languages did not appear to influence the magnitude of the difference in the performance between L1 and L2. So it seems that it's really crucial to collect information of the linguistic profile and also language history of the multilingual person with aphasia. And before I get to assessment, I need to say a couple of words on language mixing, because we often need to manage language mixing during assessment. So language mixing is a typical behavior for multilingual individuals in general. And we know that multilingual individuals with aphasia, they language mix in the same way as healthy multilinguals do. But they tend to language mix more. Some studies have shown that people with aphasia do language mix in a pathological manner due to a language control deficit, but not always. Other studies have shown that people with aphasia can use language mixing as a communication strategy to bypass anomia. And in a study, we found that aphasia severity played a role. So people with more severe aphasia language mixed more than people with milder aphasias. And they also tended to language mix more when they were speaking their weaker language. So there was probably more need for language mixing due to word finding difficulties. And in this study, we didn't find any traces of pathological language mixing. So the speakers didn't uncritically switch to languages that weren't known to the tester, the interlocutor. So if your client with aphasia language mixes, we need to check whether this is a typical behavior of that person. And if not, we need to explore the underlying cause of the language mixing. So a short interim summary. Based on the findings from the studies I've mentioned, we as clinicians, we can make some assumptions, but it can be easy to make false assumptions. So we must be careful not to assume which language will be best preserved following a stroke before we know more about when and how the languages were acquired and used. So we cannot assume that premorbid language abilities were equivalent, and therefore we cannot attribute post-morbid or post-stroke differences between the languages only to the brain damage, because the languages may have differed premorbidly. Therefore, we need to collect information about language background, and also we need to consider the various domains of all the languages with appropriate tools. So appropriate is the key word here. I will start with the first, language background. It is really important that we as clinicians, but also researchers, that we carefully collect and document premorbid proficiency and also the other factors that I've just mentioned. As I've shown, these variables significantly impact linguistic performance, and they may confound our interpretation if they're not accounted for properly. In most cases, we don't have objective measures on premorbid or pre-stroke language proficiency. So what do we do then? These days, many people tend to have videos or audio recordings of themselves. So this could be one source of information. But for the others, we often tend to use self-report questionnaires from the person with aphasia, him or herself, and also from the care partner. One challenge here is that many of these questionnaires are not designed for aphasia. I will show you one soon. And we have some that are designed for aphasia, but they can be somehow extensive. And I don't know about your family members, but I'm not sure my family members are fully informed about how proficient I am in English or other languages that they don't know themselves, for instance. If they can say that Monica's writing in English is on X level. So it may be difficult for caregivers to give a full picture. It may also be difficult to distinguish pre to post rated, self-rated proficiency. And I will come back to that MAP survey, the global survey that we conducted some time ago. And when we asked the SLTs in that survey whether they do in fact assess language background, nearly 20%, so 1 in 5, reported not assessing language background at all. And as you can see, relatively few reported that they use standardized multilingual language questionnaire, and they used a range of different tools, and most of them used Part A from the bilingual aphasia test. But most of the respondents said that they are preparing their own set of questions. So this shows that there is a great variability in clinical practice. And this can make data from different clients and different studies a bit hard to compare. So here is the language questionnaire I talked about, the LIPQ. And I will mention it because it's used in a lot of research, and also it exists in 45 languages. And it's very accessible. It can be downloaded for free in all of these languages here. And it asks about, so here the questions here are, please list all the languages you know in order of dominance, in the order of acquisition, the the percentage of the time you currently and on average use the different languages, and it's relatively user-friendly. It has drop-down menus for the different modalities. So for speaking, you can see we can click for the scale. But as you can see, there are relatively many options here. And this is not designed for aphasia, so it needs to be modified. So for aphasia, we need to ask about how was it pre-stroke and how is it now following your stroke? So how valid are these self-reports? Overall, in general, this seems to be a viable option, even if there have been reported validity issues in some studies. They may, however, be more reliable within a multilingual person's own language system. So I know my Norwegian is better than my English. And this makes between participant comparisons, they can be misleading, especially when our participants have different language combinations, different cultures, or different dominance profiles. So we cannot treat these people as they represent one homogeneous population, multilinguals. And also it has been shown that one person's max score might be more like someone else's medium score, so it can be difficult to compare. Even if multilingual speakers are pretty good at reporting which of their two languages is dominant, the extent of difference between the languages can vary with language domain and also between different measures. And this can also be challenging because language proficiency and language use change for individuals throughout their lifetime, right? And we also need to bear in mind that some people will present themselves as more proficient than they might have actually been, not to lose face. So is it a self-presentation rather than a self-report, we can ask. But self-rated proficiency measures are better than no measure at all, but it can be misleading. So a sole reliance on self-report is not advised, and we should therefore supplement with more objective measures. Okay, moving on to assessment of languages. Who should be conducting the assessment? In a perfect world, we would have multilingual clinicians with the same languages and the same cultural backgrounds as our multilingual clients. But often we find that this is not feasible. Larkman and colleagues reported in 2023 that out of the total number of SLPs in Australia, at the time a bit more than 11,000, only 12% of the Australian SLTs were in fact multilingual themselves. But so of course we cannot have these 12% assessing all our clients. So I think that even if we cannot conduct the assessments ourselves, if we not share the language with our clients, we should educate ourselves about our clients' languages and cultures. And I think we should also use interpreters. And working with interpreters is also mentioned in the position paper of Speech Pathology Australia. And this is good. In Norway, we don't have any guidelines on how to work with interpreters as SLTs. Okay, so in addition to the normal briefing we do with interpreters about procedures and roles and professional needs and so forth, I think we should educate our interpreters. Most interpreters I have worked with have never heard about aphasia before taking on working with me. So we need to educate them about stroke, but more specifically about aphasia and how to communicate with people with aphasia. And also we need to train them on how to conduct a language assessment. So when I get an interpreter, I always go through the language tool that we're going to use, item by item. And I also try to explain to them what I need from the assessment, how they should interpret and what to interpret. Because interpreters are trained to construe meaning, not to interpret word by word or sound by sound what the people are saying. And this is really, really difficult because how do we interpret speech and language errors? How to interpret apraxia of speech or dysarthria, or how to interpret language errors such as phonemic paraphasias or cognitive communication difficulties like pragmatic and prosodic deficits. It's really, really difficult. And the SLTs themselves, the interpreters themselves also report that this is challenging. Some of the interpreters I have been working with tend to give up too soon. They don't give the person with aphasia enough time, or they can expect too much. I remember so well a case I worked with many years ago. We had this young lady who had acquired aphasia, and we worked with the same interpreter on 2 consecutive days. On the second day of assessment, she performed less well than the day before. And the interpreter was so frustrated. He's like, I know you know this. You said this yesterday. So we need to educate them about aphasia and how aphasia fluctuates between days, right? And I also would advise us to be present during assessment. This way we can catch if they are pushing too much or if they give up too soon or, yeah. And after the assessment, we should have a post-evaluation talk where we can maybe try to get some help in scoring and also interpreting the results. So what about test validity and reliability? We know that interpreters may try to help or change test stimuli, or they can report wrongly back to the SLT. So he said this and that, and I can ask, did he really say exactly that? So no, but that was what he meant. So then we don't know what we are testing. And there is also some concern about test-retest issues when providing the same assessment tool in different languages. In different languages. So I've normally touched upon assessment using interpreters. If you're interested in the interpreters' experiences working with SLTs or how to collaborate with them for interventions, please check out the previous CRE seminar on Dr. Larkman's interesting studies on the topics. What about if we cannot find an interpreter? Norway is like Australia. We have huge distances and big areas without many people. So telepractice may be of help here. There are not so many studies on interpreting assessment for multilingual with aphasia, but some have shown promising results. We could use care partners. It's not ideal. Of course, this needs to be the person with aphasia's own decision, and they need even more training than the interpreters do. And what about children? This may cause stress and frustration both for the child and the parent. And I checked out different government websites of Australia. And both the website of New South Wales and the Victorian government website, they state that it's not acceptable to ask children under 18 years to interpret. So this should be avoided. Regardless of whether we have SLTs or interpreters testing, we still need to decide which language mode will we use. So I have added here Grosjean's figure on language mode. So we have a monolingual language mode on one side and a bilingual language mode on the other side. And the traditional way is to assess 1 language per session or 1 language per day. Here we try to keep a monolingual language mode with 1 or 2 testers. This allows for a more thorough investigation of the ability in each of the languages. But to stick to only 1 language may be unnatural for some multilingual individuals if they're used to language mixing. We need to think of order effects. Which language do we assess when? And also we need to consider fatigue and also an extra cognitive burden, given that all languages are active at all times and that we have to inhibit the non-target language when we are assessing one of the languages. The other approach is a multilingual or translanguaging approach. In this mode, we have probably better assessment over the overall communicative ability of the person with aphasia. And here the tester shares all the languages with the person with aphasia. So this is a perfect world, right? They will provide tasks and prompts in all of the languages, and language mixing is modeled by the SLT. It's an ecological valid method for persons with aphasia who already are used to language mixing. And of course, we need to have testers with the same language combination. So we should test all languages, but from previous studies, we know that SLTs not always do this. So in the MAP survey, we asked whether they test one or several languages of their clients. And as you can see here, as many as 40% assess only one of the languages of their client, so not getting even half the story. And the reason may be, and we asked them if they assess, for those 60% who did assess all languages, how do they do that? We see that 20% conducting the assessment themselves, so probably in languages they are highly proficient in themselves. And use of interpreters was the next most common method, sorry. But most of them reported to use two or more methods, with the most common combination being that the SLTs conducted the assessment themselves with assistance from relevant others or clinical staff. Okay, so which tests do we have? We have some different options when it comes to assessment. We have these translated tests, we had adapted tests, and also tests that are designed for multilingual people with aphasia. So even if it's strongly warned against translation of tests, these are widely used, both in research and also in clinical practice. The WAP and the Boston Diagnostics exist in more than 30 language versions, but they are all translations and not adaptations. And most of them lack documentation of psychometric properties. So we should be careful when using translation of English tests. If they're only translated, the two language versions may be of a different difficulty and may not be culturally relevant. And all of these tests usually have monolingual norms, often from a relatively small number of participants. And it's probably needless to say that monolingual norms is not appropriate if you want a realistic view of what to expect from our multilingual individuals. And finally, but not less important, little attention has been given to making the different language versions comparable, since the intention was not to test several languages within one individual. So when we use assessment tools that are not standardized for our clients, this raises serious concerns. As Melissa Bortz puts out, in these situations, we are not meeting our professional standards and we are breaching our ethics. It's harsh, but I think she's right. A test that is designed in a way that makes it suitable for adaptation into different languages and still meet the requirement of equally difficult psycholinguistic constructions is the comprehensive aphasia test. So within the CATS network, we have adapted this test into several languages. With one of the aims being to develop tests that are comparable across different languages. So we have been doing a linguistic and cultural adaptation and not translation. We've kept the same number of subtests and items, same scoring system, same underlying linguistic and psycholinguistic factors. And I think there are 19 or so published or in progress. But also for these, there are very few published comparisons. And we actually compared the Norwegian and the Croatian version, and they are not completely 100% comparable, even if we tried to make them as comparable as possible. Finally, one tool that tries to meet the requirement of being suitable for multilingual individuals and for multilingual individuals with aphasia, and it exists in more than 70 languages, is the bilingual aphasia test. The different versions are not translations, but they should be culturally and linguistically equivalent tests. So it comes in 3 parts. Part A is the background questionnaire, which assesses a premorbid language history. This we conduct in the best language of our client. We have the different language tests, which we need to test one version per language. And then for some languages, there are translation tests. But also for the BAT, there are no published norms for the different language versions. And we also have a lack of published comparisons. But one comparison that has been published between Spanish and English found unequal levels of difficulty, especially for morphology. In spite of that, it's still frequently used, both in research and also in clinical practice. We see that the SLTs in the survey use the cat and the bat a lot for assessment. So assessment is on the left sidebar, but not more than they use these translated tools. And when we ask them how happy they are with the tools that we have, they are not very happy. More than 60% are dissatisfied or very dissatisfied. Okay, so we're not happy with our assessment options. And even if the test is available in the relevant languages of a person with aphasia, the normative data are typically not available or applicable. So what do we need to think about when interpreting test scores? I think we can use the tests available in the different languages, but we need to be careful when interpreting the results. For instance, we probably should examine performance qualitatively, so which tasks appear difficult in the different languages, instead of calibrating a severity score. And we need to remember that it's challenging to determine language abilities after the aphasia onset, because what we measure with language tests in fact reflects the effect of language proficiency pre-stroke and combined with the aphasia severity. These are hard to dissociate. So we need to interpret cautiously. Since many tools are not appropriate, we should supplement the standardized tests with more unstructured assessment. So several studies have explored the difference between standardized and unstandardized assessment methods. And here is a study that was conducted many years ago. I worked with a lady who spoke 4 languages, and we provided treatment in Norwegian, her latest learned language. We provided her with a semantic feature analysis treatment targeting verbs in complete sentences. And we assessed her with different measures to detect change in all her languages. And since we were working on verbs and complete sentences, we hope to see differences or gains in both syntax and semantics. On post-treatment in the treated language, the formal and standardized test, bilingual aphasia test, showed that there were no significant improvements on syntax or semantics. So we were a bit disappointed to see that. But on the cartoon description of the bat, it showed significant gains both on different syntactic measures, as you see here, and also on some semantic measures. So using narratives to assess multilingual individuals is a viable option. Especially since we don't necessarily have tools for this group. But of course, I need to point to some of the challenges in elicited language production. So there is, of course, greater effort in preparing the data. All of these narratives needs to be transcribed. And maybe AI can be of help here at some point, but today we're not completely there. It is also greater effort in scoring the language output. We need to decide on what do we want to score, which measures do we want to look at. If we don't know the languages the person is speaking, we have less control of the language produced. And of course, we have very few or no norms for the different languages for these different tools. But there are strengths. We don't need these thorough adaptation processes that we do need for standardized measures. Connected language production is of greater ecological validity. It's a more natural way. We want to enhance communication after all, right? And it also allows for language mixing for those who are used to language mix. And we could decide whether we want to use a monolingual scoring, so score only the target language if we test in a monolingual mode, or if we will use a combined scoring or a conceptual scoring. So here is an example where the bird story in German for the same lady is scored both monolingually. So what did she, how did she produce the narrative in German? So here we have selected, this is only content words, function words, and completeness of sentences. So we can score it only for German, or we can score it combined. So we include language mixing. This way, she was able to show her whole linguistic repertoire, and it can provide a more global picture of the people's language and communication abilities. Yeah, so I think my time is almost up, so I will wrap up. So to improve the validity of our work, there are some measures we can take. To all the educators in the audience, we need to prepare our students better. We need to prepare them for working with multilingual individuals in general, and more specifically with multilingual individuals with aphasia. And we also should educate them about how to work with interpreters. We should learn about our clients' languages and cultures. And we know that I've shown that L1 is most often better preserved, but we don't know the unique characteristics of our specific clients. So therefore, we need to assess language background. We need to include detailed information about the participant's language history, the age of acquisition, mixing habits, language use, and so forth. And we need to assess all relevant languages with appropriate tools, as appropriate as they get. So we should use adapted tests as a minimum. We should collaborate with each other with multilingual SLTs or trained interpreters. And we should be cautious when interpreting the test results, since we have no norms from the population. So in conclusion, we need to be aware of and try to minimize the linguistic biases in our clinical work. And hopefully this will lead to the development of more inclusive approaches to clinical practice. I've added some selected references, and I want to thank you so much.
Thank you, Monica. That was fantastic. Okay, so it looks like we've got some people making some comments and popping some questions in the Q&A. So I might read those out, and if there's still time, I might ask a few questions of my own. So John Pierce has said, "Thanks, Monica, a fantastic talk. I wonder what you would like to see done to address the challenges if you were given unlimited resources."
I think collaborating with each other is really important. So I think the collaboration of aphasia trialists is really, really important. We need to try to make tools. I've talked about assessment today, but we also know that our treatment materials are also made for English-speaking monolingual individuals in the US, basically, right? So I think collaborations between countries, between clinics, is really important. And I don't think I think it's hard to have tools that really capture the language of our clients. Given it's impossible to have multilingual norms because the population is so heterogeneous, right? They have different languages, different times when they learn the languages, they have used them differently, they have stopped using the languages. They are messy, right? But I think, and we need to collaborate with SLTs, clinicians, researchers, also in the global south, right? We also saw on this match survey, we basically have responses from the global north, very few from the African continent, few from South America. So we have a way to go to be fully informed of all different language and life realities. Yeah. Sorry, John, it was not a proper question answer, I guess.
And then Annie Hill has got a question as well, and she thanks you for your presentation. And so Annie is interested in the use of videos or audio clips to gauge someone's pre-stroke language skills and usage. And she was asking whether you can maybe elaborate on how you might practically use those types of sources clinically.
So I haven't used those sources myself because I've asked some clients about video clips or audio clips if they have them some are a bit reluctant to share them. They think it's hard to listen to and to share what they have lost, yeah. So it can be a bit emotional and touching. But I think if we could access those data, we could use them as, at least we could transcribe them and see how was the language. Of course, we can also try to collect information about um, if somebody has done their education in Australia, you would presume that their English was relatively good before, right? But to know exactly how the languages were before the stroke, I think we need audio or video recordings, right? If we can access them, if they can share them. If we try to explain why we need them and how we want to use them, and why this is important for designing a proper therapy. Because usually we cannot train them to be better in a given language than they were before the stroke, right? We
Yes.
know about new learning in aphasia. It can be difficult.
Mm.
But I think
Mm.
it's an interesting option.
Yeah, yeah, absolutely. Um, okay, so they're the questions online. I had a couple of questions as well in relation to the assessment with adapted tools. Thinking about, here in Australia, if we were to potentially try and utilize an adapted version of the CAT for a different language. If the speech pathologist still doesn't speak that language, what are your thoughts on a speech pathologist trying to use an adapted tool with an interpreter if they are not able to read or understand the tool in the other language? What are your thoughts around that?
So this is how it usually is, right?
Yeah.
Use tools that are not normed for the
Mm.
population, right? So they all have. Also, the cat has only monolingual norms, right?
Mm.
And to me, when I work with interpreters, I always invite them to come at least a couple hours before the client comes. Of course, we need resources to do that. But to me, that's it's inherent. I go through the test and I very often, sorry, Michelle Paradis, but I very often found flaws in the bilingual aphasia test. Or of course, languages also develop. So
Mm.
interpreters may say that we don't use this word anymore, or in my region we don't use this word. Can I change the word? And then what do we do about how about test validity if we change
Mm.
items in our tests, right?
Mm.
So, but I think a minimum is to go through the material, the test, the tool, item by item. Which objects do we need? Is it appropriate for your culture? In order to try to enhance the validity, at least. It's not perfect, and I don't have the answer for a perfect assessment with interpreters. And I think you probably have encountered the same issues in your work, Chelsea.
Yeah. Yes, yeah. And I wonder also about what your thoughts are around when you're doing assessment with a bilingual or a multilingual person with an interpreter for the language you don't share, but perhaps you do share a language. What are your thoughts on then how them hearing something in their other language might influence their performance, even though you're trying to test in the unshared language?
Yeah. So this is also an issue, and I try to tell my interpreters that we want a monolingual language setting.
Mm.
So we don't want influence from the other languages, but of course, the person with aphasia know that we share some languages, right? We share Norwegian in my case, and the interpreter, they are trained to interpret online, so they're not trained to conduct a whole assessment without giving any information to me as the SLT.
Mm.
So I have some video clips that I didn't show today, but I use it for students where I say, this is a monolingual setting, you should speak only Punjabi, and the interpreter will translate to me at all times for every item. And this is not a monolingual language setting, right? So I think Mira Goral's it's really new work from her, where she's tried to explore this multilingual or translanguaging approach, where you actually are allowed to, or um, it's not only allowed, but you should speak all of the languages also in the same assessment session. I think it's really interesting, and I think we should explore
Mm.
that more. Mm.
Yeah, yeah, absolutely. Okay, well, Monica, thank you so much. That was tremendous. It's always an absolute joy to listen to you present, and I take away so many more just nuggets of gold every time I listen to you. So thank you again for such a wonderful presentation.
Thank you
Um,
so much for the invitation.
you're welcome. All right, I'm just going to share my screen again for our wrap up. Okay, so today's seminar has been recorded and it will be up online on our YouTube channel very soon. And so Monica's presentation will be up there, as well as you can explore our full library of previous sessions. So feel free to share those sessions with or catch up on any that you might have missed in the past. And so you can subscribe to the channel, like the channel, and you can also stay connected with us by following our blog, our Facebook, or our LinkedIn page. We use those forums to update on new research, share information about any upcoming studies, and also talk about any opportunities to get involved. So we will be back next month with another seminar. We have Dr. Amy Ford presenting on a framework for understanding and supporting relational recovery following aphasia. So stay tuned for that's going to be on the 24th of June, but we will share details to register for that through our socials. So thank you again, Monica, for joining us, and thank you to all our